Hi, everyone. My name is Anil Sood, and welcome to the 2022 Teal for Zeal. I'm so sorry I couldn't be there in person due to a cancer meeting that I had to attend, but I thought I would go ahead and record this presentation ahead of time. I did come prepared, though, for the Zeal for Teal event that's taking place today. Let me go ahead and pull up the slides here. You know, I just came back a couple of days ago from the annual meeting of the Society of Gynecologic Oncology from the SGO meeting. And what I thought I would do today is take a few minutes to present to you some of the highlights. This was the first meeting after 2 years. So the last two meetings were all held virtually. And this year it was held in person. So there was a lot of excitement about the meeting itself. And it was great to see a lot of the clinicians and scientists in person this year. So I obviously can't present all of the highlights, so I picked out some of the select highlights from the meeting. And what I thought I would do is share three areas where there were presentations made, and those relate to genetic counseling and screening, upfront treatment, the new developments in that area, and then also some of the clinical trials that related to treatment for relapse ovarian cancer. This was the first study, and this relates to genetic counseling and testing. This was a prospective randomized study of video-assisted genetic education, and I'll talk a bit more about this. So this was a multi-institutional study that was presented. You know, we know that genetic counseling and testing is so important for women with ovarian cancer, and it is a recommendation that all women who've been diagnosed with ovarian cancer should undergo genetic testing. However, historically, genetic counseling has been required, and that can be a potential barrier in some places where there can be lack of availability of genetic counselors. Moreover, there can be lack of knowledge about specific information about genetic testing, and also the costs and issues related to that. So this group, what they did was an important study, because we need to move beyond the traditional modes of genetic counseling. So they randomized patients toward a traditional arm where the traditional genetic counseling is done. And then they also looked at the impact of what this kind of an approach can have. And then the experimental arm, patients had same type of questionnaires, but instead of a formal consultation, they underwent video-assisted education, and then genetic testing was offered immediately after the video. The summary from this study was that the impact of this kind of a new approach using videos was really no different, meaning that patient distress and psychological impact scores were identical between the two groups. So this gives us some confidence that these kinds of approaches may help expand genetic counseling and testing beyond the traditional approaches. Obviously, more and bigger studies are needed before we feel fully confident, but this was clearly an important first step. Now I'm going to shift gears and discuss some of the findings related to upfront treatment approaches with you. This was a phase 3 clinical trial that came out of Japan that looked at intravenous versus intraperitoneal carboplatin chemotherapy. So we've known for many years now that intraperitoneal chemotherapy can be advantageous for select groups of patients with ovarian cancer. Now, in this particular clinical trial called the IPOC trial, they took women with ovarian cancer who had stage 2 or stage 2 through 4 ovarian cancer, and then they were randomized to receiving carboplatin either given intravenously or the carboplatin was given into the belly, into the peritoneal cavity. The paclitaxel or Taxol was given on a weekly basis, and that was identical. Both patients, groups of patients received that intravenously. Now, for clinical trials, there are lots of acronyms used, so I'll try to define those as I go along, so please bear with me. This study showed that the progression-free survival, so that means that, that from the point of diagnosis, if you look at the interval of time before someone had recurrence or progression of disease, was there a difference? So in this study, they showed that those patients who received intraperitoneal carboplatin chemotherapy, and that was the only variable, by the way, they tended to have better progression-free survival compared to the group that received intravenous carboplatin chemotherapy. Now, it's unclear, whether this will get adopted widely, because there have been so many other new drugs that have come about, and I'll present some data around those as well. But I think many of you know that PARP inhibitors and drugs that target the blood supply or anti-angiogenesis drugs have certainly been impactful for upfront maintenance strategies as well. The next study is actually a study that looks at the real world experience. So for use of maintenance therapy, meaning that for patients who have had chemotherapy, they've had surgery, then do they tend to go on maintenance therapy? So what this study showed that, so 1L here stands for first line maintenance. Now, this is a complicated slide, but the main 2 points that I'll call your attention to are highlighted in these red boxes. So the purple bars are those patients who receive an anti-angiogenesis drug, so bevacizumab, and the orange bars are those that relate to use of PARP inhibitors. And what we see over the course of this period of time, or since 2017, is that patients who are receiving PARP inhibitors, that proportion is increasing, and those that received anti-angiogenesis drugs is decreasing over time. And that makes sense, because as we increase genetic testing and we know the group of patients who can benefit from PARP inhibitors, we certainly expect that the use of PARP inhibitors will increase. But this gives us real world data that indeed in the United States and really all across, that PARP inhibitor usage is increasing in this maintenance setting. And that's what the conclusion is, that across all countries, there was an increased use of PARP inhibitor monotherapy in maintenance over time, and a decrease in the use of bevacizumab or anti-angiogenesis drugs. The next study is an intriguing study. It's a study that looks at niraparib, so one of the PARP inhibitors, as neoadjuvant therapy, meaning that that's the drug that's used prior to a definitive therapy. So this was a prospective, multi-center, exploratory study. It's a small study, but a very important clinical trial. So in this study, they looked at women with high-grade serous or endometrioid, ovarian, or fallopian tube or peritoneal cancer. And then these patients had either unresectable cancer, or they were not considered amenable to surgery in an upfront setting. And then they were, those patients, it was a requirement to have a BRCA mutation or HRD positive or homologous recombination defect positive disease. And then they were given niraparib every day for 2 cycles. And then if they had a response, then they underwent surgery followed by chemotherapy and beyond. So in this data here, they found that close to 75% of patients had a partial response to single agent PARP inhibitor. And the extent of response is shown in this bar graph here. So when you see the bars moving below 0, that means that the tumors were shrinking based on images. based on imaging. So again, a really exciting study that PARP inhibitors for select group of patients who carry a BRCA mutation could certainly be an important neoadjuvant approach. Here at MD Anderson, we've been doing a similar study that Dr. Shannon Weston has been leading. And our hope is that perhaps for select group of patients in the future, one could even move beyond chemotherapy. Now let's shift gears again and talk a bit about treatment of relapsed ovarian cancer, and I'll present some of the studies that were covered there. Now, one of the acronyms that you'll see show up several times is PROC, and that stands for platinum-resistant ovarian cancer. And that's typically defined as if a given patient's cancer comes back within 6 months of completing therapy, then they're considered to have platinum-resistant ovarian cancer. So the first study is the so-called SORAYA study. Boy, this is a complicated name called mirvetuximab soravtansine. And this is a drug, and I'll describe in a bit more detail, that targets this protein called the folate receptor that's expressed on many ovarian cancer cells. So the idea is that you can deliver a toxin or a payload very specifically to inside cancers that carry this particular receptor. So what is an antibody drug conjugate? So that drug that I just mentioned is an ADC, or an antibody drug conjugate. So the idea is that this orange structure here is an antibody. So you can take a connector called a linker and attach a drug to this linker. Now, this kind of a drug typically should be fairly potent, and without having the ability to deliver it selectively into cancer cells, it may not be particularly active. So the idea is that you use this antibody to get it to the cancers and then get it inside the cancer where this linker comes apart, and you release the drug inside the cancer cells. So it's a really smart strategy for delivering drugs in a very specific way. Now, this particular trial, the primary goal was to look at the objective response rate. And that means that, was the treatment effective in terms of shrinking the tumors? And as I mentioned earlier, the patients who were eligible for this trial were those who had platinum-resistant relapsed ovarian cancer, meaning that they had recurrence within 6 months after their last platinum dose. Really an impressive response rate. So the response rate was 32%, and that's shown in this graph here as well. And the DOR here stands for duration of response of almost 7 months. So this particular drug indeed showed activity in those patients who had a cancer that expressed high levels of this folate receptor alpha. And this drug will certainly continue to move forward. The next study is a clinical trial that looks at immunotherapy using pembrolizumab. So this is an antibody that targets cancers through the PD-1, PD-L1 pathway, and it combines it with a drug called nemvaleukin that uses interleukin-2 to expand the immune cells that are then allowed to target cancer cells. This particular trial was called Artistry-1. So the way this trial was set up was, again, the goal was to look at objective response rate, and the patients could have had mixed tumor types, including those who had ovarian cancer, but even patients with other types of cancer and sarcoma were allowed to enroll in this trial. For this particular presentation, they focused on patients with platinum-resistant relapsed ovarian cancer. So remember, I told you about that acronym PROC, and that was the group that was enrolled. So pembrolizumab was given at 200 milligrams, and then this nemvaleukin or interleukin-2 was given at these two different doses. Again, that same type of a graph where you see whether a cancer was stable or whether it was progressing, or as shown on the right side, was it actually shrinking? So this graph shows you data on about 14 patients, and you can see that a lot of patients, the tumors actually shrunk on this particular treatment combination. So the conclusion was that that there were 2 patients who actually had complete responses, so really exciting, out of 14 who had durable complete response, and several of the patients had at least a partial response on this regimen. So the US FDA has given this a fast track designation for this combination, and this will continue to get developed further. Another clinical trial combined a PARP inhibitor niraparib along with a drug called inlotinib, which is what's called a pan or multi-kinase inhibitor. It targets a blood supply as well. So in this trial called the Anil study, they enrolled patients with, again, relapsed ovarian cancer, whose cancer came back within 6 months period of time. Again, you're seeing a recurrent theme here, and this is this platinum-resistant relapse can be difficult to treat, and that's why there's so much focus on this. And then patients were treated with this combination of inlotinib and niraparib. Again, in terms of objective response rate, a really provocative set of response. You can see when you see that most of the bars are moving in this downward direction, that's exciting because that means that a lot of patients are deriving clinical benefit. There were some patients who had a complete clinical response, and then almost 50% had at least a partial response to this particular treatment regimen. So the objective response rate on this regimen was over 55%, so really exciting. So this kind of a regimen, we would certainly hope will continue to get developed further. Now, another clinical trial looked at, we know that ovarian cancer tissue itself doesn't have a lot of immune cells. So this group from Roswell Park was trying to use a therapy that would actually convert these cold tumors into hot tumors, meaning that recruiting immune cells within it. So they combined, again, that same drug, pembrolizumab, which is an immune drug, with a drug that targets a blood supply, bevacizumab, and then they used a chemotherapy drug, cyclophosphamide, at a metronomic, meaning at a really, really low dose, but where they just give it on a continuous basis. So 3 drugs that were used for patients with relapsed ovarian cancer. Again, you see lots of bars moving in a downward direction here. So the objective response rate approached 50%. So really exciting clinical trial here as well. And the conclusions, they showed that when they analyzed the clinical samples from this trial, indeed, they were able to show that immune cells were entering the tumor. And so they were able to convert a number of these cold tumors into immunologically hot tumors. And the thinking is that that's what's allowing the treatment to work better in terms of shrinking these tumors and so on. Now, the final part that I'll cover is a really important topic, which is access to care for cancer patients. So, Medicaid has been expanded in many states, not all. This was a study from here at MD Anderson. One of our clinical fellows, Sarah Huppenbecker, presented this study where she looked at the impact of Medicaid expansion on postoperative mortality in patients with gynecologic cancers, including ovarian cancer. We know that since in 2014, the ACA, or the Affordable Care Act, allowed states to expand Medicaid to adults who were at the federal poverty level, but it was only expanded in several states, but not all. So in this study, they found that states that expanded Medicaid since 2014 actually had improved postoperative mortality for patients with endometrial or ovarian cancer after 2014. which would suggest that perhaps access to care might be better, and that's what may be allowing better outcomes for these patients. So again, access to care is certainly a very important issue that we should keep in mind. And with that, I'll finish up. I want to acknowledge, obviously, the many authors who presented their studies and the many patients who took part in this. And I want to congratulate Runsi for such a remarkable job with setting up Overcome and the many years of advocacy and helping patients and survivors and their families. Thank you again, and I look forward to seeing you in person in the future as well.